We are live.
You're recording? Yeah. Good evening, everyone, and welcome to another session of the YOSI Journal Club. And it's a great pleasure to have all of you join us and do some brainstorming here with all of us. So I'm Dr. Digvijay. I'm the moderator, and I'll quickly run you through the concept of the Journal Club. And we'll have the slides to show you that, as well as the monthly mentor and our expert panelist today as the presenter as well. So, and you're in for a treat. It's a good study today about control of myopia progression with low dose atropine, or the LAMP trial, and we'll hear all about it now. Next, let's have the slides there. Yeah. This is the team YOSI. So all of us have been working very hard at the office bearers end to try and keep, get good activities for you. The Journal Club has been basically a brainchild of Sonal, who's been working very hard, who's our vice president, and she hasn't been able to join in today, but I know that she's there with us in this process. So next slide. So there is a team, a core team of the Journal Club, and this is the core team. It is including experts like Dr. Sabyasachi, Dr. Kaushik, Sonal herself, Nupur, Puneet, Tamunash, and the whole list of Shelja, Dr. Bhavna, and Dr. Sood as well. So all of them have been working very hard to get to you this current episode of Journal Club as well. Next slide. So the idea of the Journal Club is, so we're all after publishing, in life, or we're all saying that, publish or perish. And the idea is, so what is it that we want to know from a paper? What does a paper do? One, it obviously tells us about scientific insights, but there are a lot of ways to read between the lines that are important, right? So papers are not just about, they're not black and white about research. It's not about, the exact results are the exact results of the outcomes. So there's a lot that's there in a paper. So the idea of the Journal Club is for you to learn how to publish, how to read a paper, how to interpret it, and then grow along with it. So that's what the idea is. And it'll mean different for each one of you at your stages in your careers, whether you're starting of your training towards the ending or you're already in practice. So we'll move ahead. So when we're assessing research literature, we are basically looking at definition of the problem. We're looking at specification of the research question, definition of the variables, of how the subjects were selected, how was the appropriate research design selected, how was the analysis done, what was the interpretation of the results. So all this is what forms the way to assess in literature. And we'll just, as of each and every study that we do, we kind of discuss these more and more. So today, again, you will see most of these points getting discussed. The next we'll come to is the format of the Journal Club. So we have here a presenter, who's today is Dr. Vaishali. And then we have a monthly mentor, who's Dr. Rebecca. And since it's a pediatric ophthalmology Journal Club, so we get a specialist in that. And we have an expert panel, one which is from the research panel. And then we have subject experts and other panelists as well. We move on to the next one, which is, the MARY concept is there, or the MARY concept, we want to call it, the method, assignment, assessment, results, interpretation, and extrapolation of that. So it's a step-by-step approach to reading any medical evidence, any paper. And that's what we actually cover in the Journal Club today. And very quickly now, moving on to telling all of you to send your applications. That's how we select these cases. So you send in your applications with a paper. This is what you want to present, and we select the best one, and we get you to become a presenter. So please do send in your applications, do send in your interest and your intent on this email ID and using the Google form link here. We'll move on now. So we've had many sessions so far. The first session was a session on glaucoma that we had. Then we had endophthalmitis as the second session. We've had cataract surgery in the third session, ocular oncology. And here we are now with the fifth session, which is pediatric ophthalmology for all of you. And we're going to discuss today the 2-year clinical trial of the low concentration atropine for myopia progression LAMP study, which is going to be presented to us by Dr. Shelja and is going to be under the Vaishali, with Dr. Vaishali under the mentorship of Dr. Rebecca. Now, our experts panel, and who's going to be telling us a lot about the statistics involved, the biostatistics, is Dr. Sabyasachi. He's a VR surgeon practicing at Future Vision Eye Care Center in Mumbai. He's currently the associate editor for the Indian Journal of Ophthalmology. He has a great interest in research, has his own research academy that he's running, and he gives research cum clinical fellowships he's done from Shankar Netrale. And he's also done research fellowships at Wilmer Eye Institute, John Hopkins, USA, and he's got a great in-depth knowledge about research. He's got various awards as well, and he has published 90 plus papers, probably must have crossed 100 by now. And he's the founder of Sen Gupta's Research Academy, and it's one of the best portals that I've seen, which is providing e-learning on research. And he has his own research courses there that you can go ahead and participate in and learn a lot. I will be very happy to have him here, and he'll tell us some very nice pointers. Next, we have the expert panel, which is going to comprise of Dr. Shailja Tibrewal, who is a consultant at the Shroff's Charity Eye Hospital here in Delhi since 2013 in the Department of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology. She's in charge of the genetics clinic at the Shroff Charity Eye Hospital. Into education, her education and training, her MBBS has been from Mumbai, Grants Medical College. She's done her MS from Jaipur, SMS Medical College, and is a fellowship from LV Prasad Eye Institute. She's been the recipient of various awards and has a research interest in complex strabismus, pediatric ophthalmology, genetic disorders, and therefore she's heading the genetic clinic there. And as you can see, she's got plenty of awards and honors to her name. And she's involved in the training of fellows, DNB students, and she'll be an asset to today's discussion. Let's move on to Dr. Kaushik, who's a consultant at ESG Eye Hospital. He has been with me at the RP Center of Ophthalmic Sciences, AIMS. That's where he's trained earlier. He's also the Associate General Editor of Clinical Case Reports published by Wiley. And he's the Editor-in-Chief Ophthalmology at Staples Publishing, Florida. He has plenty of awards and honors to his name. We have with us Dr. Nilutparna Deori, who's now a consultant, an associate consultant at Sri Shankaradeva Netrale at Guwahati. That's also where she has trained. Her initial training was from the Assam Medical College, and she's also done a fellowship on orbit and oculoplasty, as well as pediatric ophthalmology from Sri Shankaradeva Netrale. She's got plenty of publications, a research interest, and an interest in teaching. She's also won awards, including the APO Achievement Award. She's been actively involved in surgical skill transfer, and she's a very active member of YOSI. She's an executive member. And one of her areas of interest and research, her vision is to keep working in the field of research, and that's what she's doing. And she's going to be an asset again in today's expert panel for all of us. We have Dr. Bhavna Khurana, who has completed her MS from Guru Nanak Eye Center, New Delhi, Maulana Azad Medical College, and is currently has a fellowship in orbit and oculoplasty and ocular oncology from Narayan Netrale in Bangalore. She is currently practicing at the Khurana Eye Center in Rohtak, and she's a pediatric ophthalmologist, strabismus, an oculoplastic surgeon, and a facial aesthetics specialist. And she's also going to give us insights on today's paper. The mentor today, and I'm the monthly mentor, and I'm pleased to say that this is Dr. Rebecca Thiman. She has been with me at the RP Center for Ophthalmic Sciences at the All India Institute of Medical Sciences. She's currently an assistant professor there, so she's done all her training in that place. She's spent plenty of years. She's got 70 plus publications there, and has got many book chapters, and she's into hardcore academics and research. Her areas of interest have included pediatric ophthalmology and strabismus, and particularly pattern strabismus. She has presented several free papers in national and international conferences, and she's been a co-instructor in various conferences in her specialty. And she's got lots of publications on myopia, and she's doing ongoing a lot of work in myopia currently, and RP Center itself has been doing a lot of work. And so she's the ideal person to be a monthly mentor. And it's in fact an honor and pleasure to have you here, Rebecca, for this session.
Thank you so much, sir.
And it gives me a greater pleasure and honor to introduce our presenter today, and Dr. Vishali Rakheja. She is done her MBBS from Chandigarh, and she's done her MD ophthalmology from AIMS New Delhi. She's currently the senior resident there, and she's in the glaucoma strabismus neuro-ophthalmology unit there, and has been doing a lot of work in pediatric ophthalmology, seeing a lot of pediatric cases. She has about almost 10 publications in index journals. She's got a book chapter, and months, she has been conferred with by the Best Junior Resident Award at RP Center, and that is indeed a prestigious award. I know it. In the year 2017-18, and she has won the first prize in RPC Ophthalmic Quiz in 2017. Welcome, Vaishali, and thank you for choosing this paper and being willing to present here.
Thank you, sir.
So at the end, thank you, Dr. Digvijay, for all the introductions and nicely starting the session. It's my pleasure indeed to introduce you today. And he actually requires no introduction. He's the president of the YOSI and also the treasurer of the Indian Neuro-Ophthalmologic Society. He has special interest in pediatric ophthalmology, strabismus, neuro-ophthalmology, and glaucoma. Innumerable publications, awards, book chapters, and we all have heard his lectures and have been in awe of his detailed knowledge and presentations. And he has great interest in technology and is co-founder of the company Kalpa Innovations, where he has developed an artificial intelligence tool for glaucoma called the RIA-G. And he was also a research guide, co-guide, and advisor to over a dozen students from different universities across the country. So thank you, Dr. Digvijay, for being a part of this and initiating and so ably carrying this forward. These YOSI journal clubs have indeed been very useful, and to some of the feedback that I get from fellows and residents. So probably we should start now.
Yes, thank you, Dr. Shelja. And I think without further ado, I'll now hand over the stage to Dr. Vaishali, because that is what we're all here to listen now to the study and your presentation, and then we'll discuss it thereon. All yours.
Thank you, sir. So is my screen visible to everybody?
Yes.
So good evening, everybody. At the very outset, I would like to thank the Young Ophthalmologist Society of India, all the panelists, and my mentor for giving me this opportunity. Today, we will be discussing the phase 2 results of LAMP trial. So as we all know, the incidence and prevalence of myopia is rising at an alarming rate worldwide, especially in the Southeast Asian continent. And nearly 50% of the world's population is expected to become myopic by the year 2050. Peeping into the Indian scenario, in India, the annual incidence of myopia has been described to range from 3.4 to 4.7%. And recent meta-analysis have shown an increase in the prevalence of myopia, both in urban and rural population. So myopia or short-sightedness is basically defined as focusing of the image ahead of the retinal plane. And it is proposed to occur due to complex interplay of various factors such as genetic, ethnic, and environmental factors leading to abnormal axial elongation. So as we all know, a normal neonate is born with a hyperopic refractive status and undergoes these three processes of axial elongation, flattening and decrease in the corneal power, and decrease in the lenticular power to achieve the emetropic status by the age of early adolescence. So if there is decoupling at any of these stages, it will lead to an abnormal axial elongation occurring without flattening and decrease in corneal power and without a decrease in lenticular power, leading to myopia. Also, the role of peripheral retinal hyperopic defocus has been described, especially in patients of ROP, in which mid-peripheral retina has been ablated by laser. So many pharmacological and optical modalities have been tapped for treatment and preventing the myopia progression. And recently, there has been a surge in the studies studying the role of topical atropine drops. So because of the accommodative and non-accommodative mechanisms, atropine has recently been studied. The first landmark trial, that is the ATOM-1 study, it studied the role of 1% atropine versus placebo over 2 years, and it also evaluated the myopic rebound. It definitely proposed that 1% atropine exerted an anti-myopia effect, but because of the high propensity of the side effects due to pupillary mydriasis, such as photophobia and blurred near vision, this could not be applied to clinical use. Then came the ATOM 2 trial, in which lower concentration of atropine, such as 0.5%, 0.1%, and 0.01% atropine, they were used. They also evaluated the myopic rebound and retreatment, and out of these three concentrations, 0.01 was proposed to be the best one. However, this study lacked the placebo group. So this led to the inception of the LAMP trial that we'll be discussing today. It was divided into 4 phases. The first phase studied the efficacy and clinical safety of various low concentration atropines versus placebo over 1 year, and the results were published in 2018. The phase 2, which we'll be discussing today, studied the efficacy and clinical safety over 2 years with the switchover of the placebo group. The phase 3 that will be studying the rebound phenomena after washout over 12 months, and the phase 4 that will be studying the long-term efficacy and also the requirement for retreatment. These 2 phases are being undertaken and the results are awaited. So the article that we'll be discussing today is 2-year clinical trial of the low concentration atropine for myopia progression study. It was published in Journal Ophthalmology, which is a journal of American Academy of Ophthalmology, with an impact factor of 4.48. So what was the rationale behind this study? As we have read, the LAMP phase 1, it demonstrated a concentration dependent response to topical atropine, and 0.05%, that was the maximal concentration of the atropine used, that demonstrated the best anti-myopia effect. However, certain questions were still left unanswered, such as which concentration will confer the best efficacy over a long term, 2 years, and will the efficacy of low concentration atropine be better in the second year as compared to the first year? Will the side effects, which were largely tolerable during the first year, will they remain tolerable in the second year also? And what will be the efficacy of administering 0.05% atropine in the placebo group of the first year? So a randomized double-blinded single-center trial was conducted over 12 months in the Eye Center of Chinese University of Hong Kong, and it recruited 383 out of 438 children from the same cohort as of LAMP 1 trial. So the subjects aged 4 to 12 years with a myopic refraction of at least -1 diopter, astigmatism less than or equal to 2.5 diopter, and a documented progression of at least 0.5 diopter in a previous year, they were recruited in the study. And the subjects with any other ocular diseases and use of any interventions apart from atropine previously, and also a known allergy to atropine, they were excluded from the study. So coming on to the assignment of the groups, the group 1, group 2, and group 3, they continued to receive the same concentration of the atropine as they were given in LAMP 1. However, the group 0, which was the placebo group of LAMP 1 trial, was now switched over to receive 0.05% of atropine drops. The trial medications, they were packaged as monodose preparations, which were preservative free, and they were administered once every night. Photochromatic glasses and progressive glasses were prescribed wherever necessary. The primary outcome of the study were the change in spherical equivalent over 2 years, and the secondary outcome was the change in axial length over 2 years. The spherical equivalent and axial length change was also compared in the first year versus the second year, and the side effect parameters such as loss of accommodation amplitude, change in the pupil size, change in the distance and near visual acuity, and vision related quality of life were also assessed. So the mean values of the ocular parameters from both eyes were computed at the baseline visit, and then they were compared at each of the follow-up visit. The analysis was repeated, adjusting the confounding factors such as age, gender, and baseline spherical equivalent, and the SPSS Statistics version 24 software was used for the statistical analysis. So moving on to the results, out of 383 subjects, 88 subjects dropped out of the second year trial, and still the trial was completed with an average completion rate of 91.3%, which is quite good. Having a look at the baseline characteristics, we can see that the average spherical equivalent at baseline was -3.9 diopter, and the average axial length was around 24.80 millimeter. Also, having a look at the environmental factors, we can conclude that this cohort was engaged in strenuous near work with about 15.7 hours per day devoted to near work and just 2 hours per day devoted to outdoor activity. So the primary outcome, that was the mean spherical equivalent change over 2 years, it showed the least progression in the maximal concentration group, that is the 0.05% atropine group, and it showed the maximal progression in the group 1, that is 0.01% atropine. Also, 52.7% subjects in the maximal concentration group, they showed slow progression of less than 0.5 diopter over 2 years. And 19.2% subjects of the minimal concentration group, that is the 0.01% atropine group, they showed the rapid progression of more than 2 diopter over 2 years. And the comparison of spherical equivalent difference between the first and the second year, that was significant in the 0.01% group and of course in the switchover group. So this is a graph demonstrating the change in the spherical equivalent, and we can see that maximum spherical equivalent change is noticed in the minimal concentration 0.01% group. It is even more than the switchover placebo group. This bar diagram demonstrates that the maximal maximal rapid responders were seen in the minimal concentration group, with 19.2% subjects showing progression more than 2 diopter over 2 years, whereas in the maximal concentration group, more than half of the group, they showed slow or no progression with less than 0.5 diopter change over 2 years. The secondary outcomes, that was the mean axial length elongation over 2 years, it was not significant only in the maximal concentration group, whereas in the group 2, 1 and the switchover group, the mean axial elongation was significant. Also, comparing the first and the second year axial elongation, we can see that the lower concentrations, they showed a cumulative effect, whereas in the higher concentration, no significant difference is seen. The distance and the near best corrected visual acuity were not affected, and the accommodation amplitudes and pupil size, they also showed a similar concentration dependent response. The most common adverse effects observed with topical atropine were allergic conjunctivitis and photophobia occurring due to pupillary mydriasis. At the end of second year, about 30% of the subjects needed photochromatic glasses. Despite these adverse effects, this trial ended with a compliance of more than 91% in the 4 groups. There was no significant difference in the vision-related quality of life amongst various groups. So this table basically demonstrates the increase in the use of photochromatic glasses and progressive glasses in the second year as compared to the first year. So moving on to the discussion, LAMP1 had already established that 0.05% topical atropine exerted a better anti-myopia effect than the other 2 concentrations, and LAMP2 reinforced this finding, and it showed that this concentration dependent response persisted in the second year also, where 0.05% concentration fared better. All concentrations were well tolerated. The pupil size and accommodation amplitude loss was largely similar in the 2 years, and despite of the increase in the proportion of photochromatic glasses during the second year, rest side effects were well tolerated. So comparing it with the ATOM2 study, we can see that the 0.01% of the LAMP2, it fared poor compared to the 0.01 of the ATOM2. It showed more progression, almost double as that of ATOM2. And whereas the 0.05% concentration of LAMP2, it showed almost similar efficacy as compared to the 0.01% of ATOM2. So this difference, it may be attributed to the difference in the ethnicity and the baseline characteristic of the cohort, and also because of the difference in the biological preparations of the atropine that were used in the 2 studies. Also, another effect was noticed, the concentration of atropine, that is 0.01% atropine, both in ATOM2 and LAMP2, where they fared better in the second year, whereas the higher concentrations, which are expected to reach a threshold right in the first year, does not demonstrate this cumulative effect. Comparing LAMP2 to an Indian-based cohort, the atropine for treatment of childhood myopia in Indian study, it was a randomized double-blinded eccentric trial enrolling 100 children who were enrolled to receive 0.01% topical atropine versus placebo over 12 months. So as we can see, the mean change in spherical equivalent and axial length after 1 year in the Indian cohort is less as compared to the mean changes in spherical equivalent and axial length of LAMP1 and LAMP2 both. And also the percentage of rapid progressors in the Indian cohort is less as compared to the rapid progressors even in the maximal concentration of LAMP2. So coming on to the MARI framework, it was a randomized double-blinded study which enrolled 383 myopic children and studied the role of various low-concentration atropine eye drops. The power of study is not mentioned. Moving on to the assignment, the same cohort as that of LAMP1 was enrolled for the LAMP2 trial, and the placebo group was switched over due to ethical reasons. So the very purpose of LAMP2 against ATOM2 study was defeated here. The outcome measures included change in the ocular parameters and the side effects. The Hawthorne effect may have led to behavioral changes and may have impacted the environmental factors such as the duration of near work and outdoor activity, having a confounding effect in all the 4 groups. So at the end of 2 years, myopia progression was minimal in 0.05% group, and it fared better than the other 2 concentration. It showed almost double efficacy as compared to 0.1% atropine group. A cumulative response was seen in group 3, that is 0.01%. And apart from photophobia, the other side effects were largely similar across both the ears. So we interpret that low concentration of atropine exert a concentration-dependent anti-myopia effect. And in this study, 0.05% atropine demonstrated the best effect. However, the rebound phenomena and the retreatment phenomena have not yet been described. So just projecting these results onto the clinical scenario cannot be done. As the ethnic and behavioral differences influence the myopia incidence and progression, these results cannot be extrapolated onto the Indian population. As in the study conducted on Indian cohort, we have seen even lower concentrations have demonstrated a significant response, and also the percentage of the rapid progressors is less in the Indian cohort. So though the 0.01% atropine has now become commercially available and is being widely used for preventing myopia progression, the higher concentrations of atropine as were used in the LAMP2 trial may be considered in the poor responders. Thank you.
Thank you, Vishali. I think that was very well presented, and thank you for putting it in this format. And this is typically for all the audience members and for people in the future who want to present this. This is the kind of format that we want you to present in. Now, this is the LAMP studies. These studies on myopia progression are indeed landmark studies on their own, because they are defining the way treatment of this has to happen in the future. But we need to read a little further to understand, what these studies say. Is it exactly what it is, or what are the, what is the critical appraisal of the study? So to begin with that, I will invite Dr. Sen Gupta to talk about the study design and the statistics involved, and followed by Dr. Kaushik Tripathi for his opinion on the same.
Thank you, Digvijay, and great presentation, Vishali. So I'll quickly just share. So I've annotated a bit of things on the. Yeah, I think you were able to see this. So first thing is that there are 4 groups in this study. That's actually quite uncommon to have so many groups in a randomized trial. And also let's understand that when you have 2 groups, that's probably the best study design. When you have 3 groups, the study design slightly weakens. When you have 4 groups like this, that is the 4th group being the placebo group, the study design keeps weakening as and when we keep increasing the number of arms in the study. So that's sort of the first thing that I thought we'll share with all of you. The second thing is that there is this element of a switchover design in this study, where that placebo group actually was switched over to 0.05% atropine group at the end of 1 year. So this is again adding a bit of complexity, and I think this group sort of needs to be looked at separately compared to the which they actually have done, to be honest. But this is a slightly separate group compared to all the others. So sort of something to think about for everybody listening is that this is a switchover or a crossover design which is incorporated into the whole RCT. Coming to a bit of the statistics, so I won't go into a lot of details. A couple of very important points. When you look at the mean and standard deviation in this, they say the mean statistical equivalent progression was 0.55 plus or minus 0.86. Now that 0.86 is actually standard deviation, and the standard deviation is much larger than the mean itself, right? This really suggests that there is a lot of deviation on either side of that mean. So essentially what it suggests is that there probably are many extreme values. These are called outliers, right? And the distribution is not normal. So if you plot this on a graph, you will not get the normal bell curve. So these are not normally distributed. In such cases, it's always a good idea to present medians with interquartile range and not means, right? So this can be slightly deceptive because this 0.55 really is being influenced by many outliers in all of these groups. So if you see all of these 0.85 plus or minus 73, this is also very large standard deviation. Against all of these, everywhere this is axial length, right? 0.39 plus or minus 0.35. So I would have liked to really see medians. There is no median anywhere through the paper, including the graphs. So it's slightly difficult to really understand. So when you have large standard deviations, always present the median. That's sort of one more take home message. And then they have done pairwise comparisons here. So group 1 versus group 2, group 1 versus 3, 2 versus 3, 3 versus 4. So all of these pairwise comparisons are there. All these p values are there in the in the table. So it makes slightly confusing. When you compare across 4 groups, we would use the ANOVA. Here we are comparing pairwise, right? So again, slightly something which is not expected. We would also like to see that ANOVA value, right? The overall p value across all the 4 groups, that could also have been presented. Then a couple of more things. So the consort diagram is actually really well presented. So anyone really looking to make diagrams, so this is sort of a great example of how to do it. Yeah, now they talk about the photopic pupil size not being affected at all, but actually if you look at the tables, this the 0.05% atropine group, the change in photopic pupil size is 1.25 millimeters. It's quite large compared to 0.02 0.025 0.67 millimeters. Again, you see the standard deviations are very large, right? So there are a lot of outliers in all of these which are hidden somewhere. I don't know how they have sort of compensated for all of that. So overall, the photopic pupil size definitely seems to be more in the atropine group. So that is sort of a bit of a price to pay for non-progression. Also, if you see the mesopic pupil size, again, it is much larger. Also, if you see the accommodation amplitude change, again, it is much larger. So there's a lot of problems with, I'm sure there are problems with near vision in these kids who are using 0.05. So that is something which we need to keep in mind. And the study from from India, which has nicely shown that 0.01% actually works as well in Indian eyes, it's also, I think, encouraging, because subjecting patients to 0.05%, we might also be subjecting them to all of these issues, which the authors I think somehow underplay, but they are also there. And lastly, when you look at these graphs, these are all these bars, these are actually standard errors, right? So none of these are really giving us examples or showing us how many outliers are there, or how many of these extreme values are there, how they may be actually manipulating the whole results overall. So that is something that we need to consider. So final take home message is, if the standard deviation is so large, present the median, and use appropriate statistics to sort of overcome these things. And that's pretty much what I wanted to share.
Thank you, Dr. Singh. I think that is indeed good tips for everybody to take home.
Right.
Kaushik, would you like to add something?
Yes. Dr. Sengupta sir has already discussed all the salient points. What I want to discuss is that when you want to take this thing into our clinical practice, there are many things which have to be looked into this, because the patient profile was all were Chinese patients, and they had near activity for more than 15 hours, which is quite high, and also compliance to the drug is also an issue. Considering this was a randomized control trial, they had many people who left out the trial before it finished. So that is another thing which we have to look into, and also the thing which Dr. Sengupta has highlighted, that this is too early to say that 0.01% is inferior to 0.05%, because this is just a single trial and we need more data on this.
So thanks, Dr. Kaushik, for your thoughts there. And so one of the things I think, Dr. Singupta, that I wanted to ask, and something that probably will give us all knowledge is, so when these trials are running over time, sometimes, for example, they decide to cross over because the placebo is not doing a good job, or there is there's a potential harm that could be happening to one of the groups. So in your knowledge, is it the ethics committee which keeps looking at these interim results in between, or is it the authors themselves who would be doing that? What is the process around it?
Yeah, am I audible?
Yes, yes.
So yes, I think there are a couple of things. One is this: there is a data safety monitoring board usually, and these bodies keep looking at these multi-center trials, or in this case, it's a single-center trial, of course. But these data safety monitoring committees keep looking at these. Now, the primary endpoint was 1 year, right? So so it's not really ethical as well, even from as an author also, or as a primary investigator or principal investigator, I would also not keep subjecting these children, given the results that we are seeing. So at the primary endpoint is a good time point for us to switch if that is indicated. So a lot of studies, including the rise and ride and a lot of these other diabetic retinopathy studies, have also done a switching at the end of 1 year, where those placebos were then given ranibizumab and then shown good effect. So data safety monitoring committee, as well as I think it's sort of the the ethical responsibility of the PI itself to think about these things.
Yes, I think that's something that was always intriguing to me, that who takes the call at the end of the day. But so
Sorry to
yeah.
interrupt, Dr. Vijay. I want to ask one question to Dr. Sengupta. You mentioned that the pair analysis is not really suggested for these where there's multiple groups. It should be ANOVA. So how would the results vary if one is used over the other?
Yeah, so I think they should present both the p-values. I mean, p-values from both the tests. And I think sort of sometimes these differences are glaring. Like in this case, there's quite a huge amount of difference. So I would really want to see across the board, across all patients put together, does it really make a lot of sense? Because when you do pairwise comparisons, sometimes data may be misinterpreted. So it is a good idea to present both. Present ANOVA, may not be in tables, but or you can put a footnote and say I'll put an asterisk if the p is less than 0.01 with ANOVA. So it's just that if there are no asterisks, that means none of the ANOVAs were positive or were significant, and that really would make me think slightly differently, that across the board p is not significant, but pairwise there are some differences here and there. So something more for us to think about.
Okay.
Right. So I think moving on, I would. So the audience are free to ask questions who joined in on the Zoom as the audience. You can always type in your questions in the chat and we can take them up as it comes along. Meanwhile, I'd now like to invite Dr. Shelja to give her thoughts on the study, particularly focusing on the positive aspects and what you thought about the study.
Yeah, thank you. So the trial, I mean, the statistical points are already Dr. Sengupta has pointed out, but from the clinical aspect, the positive point that I see from this trial is that it gives a concentration dependent effect and kind of tells you like what else can be done for patients who are still progressing on 0.01%. So what we see clinically also is that the moment 0.01% was in market, we started using it right, left, and center, and we see that in spite of that, there is a group that progresses. We don't know what difference in that group is that it progresses more, and it is seen in most populations, and probably that is why the mean and the standard deviation is too broad, because some would be progressing despite whatever concentration you use, and there it calls for either a BD dosing or a combination treatment with contact lens as well as this. So probably in such cases, maybe one can switch to a 0.05 concentration in if it is available. So that is the positive kind of a ray of hope that I would take from the study, that you have some options available. Like 1% has too many side effects. So it is like a concentration dependent effect, as Vaishali has already mentioned. So that is the strongest point. But of course, we need more studies. We need to see the rebound effect. So from the atom 2, the rebound effect was least in 0.01%, and that is why it gained so much popularity. because the effect, the anti-myopia effect was similar across the concentrations used, but the rebound effect, it was said that 0.01, although a little bit lesser effective, like the higher concentration, like 60% progression rate was controlled. With 0.01, it was 50%, but it sustained. The rebound effect was much less, around 24% as compared to 50 and 60% in the other groups. So that we need to see with 0.05% also, and only then we can probably decide that whether this is really happening. And myopia, probably there's a population dependent effect, so we have to have more studies from India, probably maybe in multicentric, so to have our own, atoms kind of studies.
Right. Thank you. Dr. Bhavna, are you there? Would you like to hear your thoughts on the study? You've been able to join. Think probably not, right? Okay. In that case, let's come to Dr. Nilutparna. And Dr. Nilutparna, from
Yes.
you, I'd like to know a little bit about the concept of myopia progression control. What are the options that are there? And in your practice, how do you go about it? And your thoughts on the study.
Yeah, I first and foremost, I would like to congratulate Dr. Vaishali for such an excellent presentation. She's really done well, and she has put forth the points very well. So in my context, since I come from the northeastern part, we belong more to the Asian group. So what we have seen is the progression of myopia, although it is more in this part of the country, but currently we are not using ortho-K because of the financial thing, but we are definitely using 0.01 concentration of atropine. And in terms of progression control for the progression of myopia, I would like to say that there are various factors that plays a role. Especially one is the genetic factor, that is the ethnicity, which is of real importance. We have seen in this study also, because we cannot compare other ethnicity to the Indian population, or rather even in the Indian subcontinent, you cannot compare with the northeastern population with the rest of the part of the India. That is one. Second part is the environmental factors. These are modifiable factors, especially the screen time and outdoor activities that has been documented. And apart from the use of pharmacological therapy, I would also like to say there has been various studies. We all know about the COMET study that basically concentrated on the relaxing the accommodative effect. And we already have, like in the chat box, we're discussing about the DIMS thing, that is the defocus incorporated multiple segments, where the central segment is 9 millimeter. And here they are not relaxing the accommodation. They are basically concentrating more on the myopic defocus. So the basic idea about controlling progression of myopia is on the principle that you want to control the myopic defocus, because that itself holds the key to slow down the progression of myopia. And even orthokeratology, that is the contact lenses, also is based on the principle that when you flatten the central cornea, your peripheral, mid-peripheral cornea heapens up, and then it causes a myopic defocus. So regarding this study, although the concentration is increased, and Dr. Sabyasachi has also pointed out that the pupillary dilatation is more, and leading to this use of photochromatic glasses even in the later part of the study. So I would like to say that we can have a combination of both spectacle correction, or maybe optical correction, in the sense spectacles or contact lenses, along with 0.01 concentration. So that would be my take on this study. I think anybody would like to comment on that.
Yes, ma'am, you're right. So basically, the main thing is the ethnic difference. So that is what you, if sir allows, I would like to share slides related to it.
Yes, sure.
So I'll just share my screen, sir.
In fact, you can share your experience as well, Rebecca, and your thoughts up right after that, because it's over to you actually.
Yeah, thank you, sir. So basically, yes, ethnicity plays a very major role. So if we have a look at this table, we see that Chinese population has the incidence, the prevalence that is way more than the Indian population, and also as compared to European and the Caucasian population. But we also cannot ignore the fact that in the last few decades, the prevalence has been increasing in India. And considering that the lockdown situation and a lot of near activity has increased in kids during the lockdown, it is anticipated that it can, push these kids who are at the risk for myopia further towards, the risk of the greater progression in them. And also, if you look at the mean myopia progression, so as Indians, we are definitely a low progressing cohort. So that is an important factor, and that's why the effect of atropine will also be different in the different ethnicity. Now, acceptance of atropine therapy in India, well, it has become commercially available. So that is a very important point. A lot of various countries, like it is still not FDA approved, it's still not available in a lot of European countries, and even in East Asian countries, maybe Singapore, Malaysia, India are one of those few countries where you have a commercially available preparation. So that also influences the results, that which type of preparation you're using. So it's being readily adopted in India because it's commercially available, the ease of administration, affordability, and of course the safety profile that has been seen with 0.01% atropine. So this was the study, and this was a multi-centric, double-blinded RCT that was done. And the Apex Center was the RP Center, and the other centers were Narayan Nethralaya and Center for Vision Eye Surgery and Shankara Nethralaya in Chennai. So the inclusion criteria was similar to what was taken in atropine and LAMP, just a little age difference, 4 to 12 years. And the important thing in any of these therapies would be there should be a documented myopia progression. So we cannot use these therapies in a child who is stable. Then we just randomized them 1:1. It was a HS dosing that was given to them, and the results were seen at 1 year. So we had 100 patients, and so as we can see in the results, the spherical equivalent, and we have compared it with the LAMP. So one is the baseline age that was seen in our study was 10 years versus LAMP that was 8 years. Then baseline spherical equivalent was minus 3.5 diopters versus LAMP, but it was minus 3.8. And the mean progression in the placebo group. So this gives an idea that the mean progression in Indian population is definitely less as compared to what is seen in the Chinese cohort. So this is one factor. Then looking at the results, this was at 1 year, the change that was noted, a statistical significantly lesser progression noted in atropine group in terms of spherical equivalent. But we must also keep in mind that axial length is not showing a statistically significant difference. Now, this has been explained in the ocular biometry study that was done by the LAMP, and they have told that these two parameters will not parallel each other, although they still believe that axial length, the effect on axial length seems to be the most important factor for the anti-myopia effect of atropine. And they explain it by saying, it is probably because there are two types of growth. One is the normal age-related growth that is happening in the eye, and the other is the myopia-related excessive growth. And and the atropine is kind of, inhibiting that extra growth probably. So therefore the ratio is around 0.7 to 0.8 versus so the effect is not parallel to each other. So this we must keep in mind, because this need further evaluation, that why the axial length change doesn't show a statistical significance with low dose concentrations. And comparing percentage wise, well, our cohort found a 54% lesser progression versus LAMP that showed a 27% lesser progression. So this indicates greater response in Indian scenario. And axial length change in both the studies, the 0.01% did not show a statistical significant change in the axial length, but it's 21% in our Indian scenario, because compared to 12% in the LAMP study. So, and looking at the progressors, well, rapid myopia progression was seen in none of our patients in the atropine group, and only 9% of patients in the placebo group, compared to LAMP, where we see that how high the percentage is for rapid progression, whether it's with or without atropine. So my concluding remarks would be that as of now, the most feasible, most affordable, and the most acceptable safe therapy for progressive mild to moderate childhood myopia is 0.01% atropine in Indian population. We might consider the optical modalities, combination modalities, but still the future studies are needed to design them. Like we have, in projects in pipeline related to orthokeratology, multifocal, and even we are trying to acquire DIMS lenses, as Dr. Shane Gupta was talking about, in order to, do some research related to it. But I think the challenge would be to safely prescribe them in the Indian kids and the patient profile that we see. And therefore, the optimal approach would be to initiate the treatment in progressive myopia with 0.01% nightly dose. Actually, multiple dosing has also been, there's a lot of talk about it, but there is no scientific evidence. So of course, we need studies to even confirm the dosing, whether it could be increased to, twice daily dosing. And in poor responders, non-responders, consider stepping up to higher concentrations. But these higher concentrations are not commercially available, so you will have to reconstitute them yourself. So, and remember the ideal indications, and workup becomes very important at baseline and on follow-up. A cycloplegic refraction, ocular biometry, especially for the axial length, so that on follow-up you can definitely assess the progression or whatever the status is. And of course, there remains a lacunae, the need for future studies for evaluating the role of different atropine concentrations, different dosing patterns, and duration of therapy, and even rebound phenomena, which is still to be, has to be still reported by LAMP phase 3. So that would be my conclusion, sir. Thank you.
Thank you, Dr. Rebecca. I think that's very nicely put. So a quick question to you. So in your practice, how do you choose the patient on which you start your low dose atropine? I'm sure you're using it even in your clinical practice apart from projects.
Yes, sir. So basically, the ideal age, they say, is 6 to 12 is what has been studied, or 4 to 12 or 14 years is what is studied. So that's the age group. Progression, that should be documented. So if a child comes to us and he just says, so sometimes we have to rely on the patient's history. He says that the glasses have been increasing, he has got a change in glasses. So we can rely on that. Second, if the patient has a previous refraction and current refraction shows a progression of more than 0.5 diopters. So these are the two things. But if the patient doesn't have any documents and doesn't show any decrease in vision, doesn't give a history of decrease in vision lately, so we follow up these patients. We just keep them on follow-up without any intervention for maybe 3 months. So 3 monthly follow-up, we observe them. It's only when we note a progression, we start them with the commercially available 0.01% atropine preparations. And we follow them up initially 3 and then 6 monthly. So that's how we do, sir. And duration that has been recommended is 2 years as of now. But thereafter, probably we can just follow these cases, assess if it's still progressing, we can restart the therapy.
Right. And Dr. Shelja, is that how you're also practicing, or are you doing it very differently?
Majority is similar to Rebecca, but then there are some concepts like the concept of pre-myopia and the concept of risk factors in a case where there is no progression yet. So in those cases also, sometimes I do start. For example, if it's a very young child, because most studies show that the younger the myopes, the greater the progression. So if it's like a 4-year-old who comes to me with a -4 in the beginning itself, the parents are also myopic, does not have much of outdoor exposure. So that would prompt me to even consider 0.01% in that child also, even in the first go. And of course, I don't give it for pre-myopes. So for everyone's clarity, the pre-myope would be a child whose refractive error is not myopia, but it is more for the age. For example, if a 4-year-old child has a -0.5 also, but at that point it should be 0 or maybe a little bit hyperopic. So those children probably need a quicker follow-up or earlier follow-up to see if they convert to myope. So these are the two differences that I would do in my practice. Yeah. And these are recently, probably maybe 6 months or 8 months before, I was just following exactly what Rebecca did. But recently I have shifted a little bit because of the risk factors, and some of these children have progressed despite 0.01%. So I just, I'm a little careful and start them a little early now to whatever.
No, I agree with you, ma'am, because at least for pre-myopes, we keep them on regular follow-up. And if it's a documented progression, then that becomes an indication. True.
Yeah.
Yes.
Yeah. So there is even a study on pre-myopes where they've used 0.01% and showed that it was a RCT only, and they showed that it did help in reduction of the onset of myopia. So there are two concepts to myopia treatment. One is prevention of the onset, and then the prevention of progression. So some of these things like outdoor activities, they have more effect on prevention of the onset. That's, you start them with the lifestyle modifications even before, and these become more important in pre-myopes and, children with parents with myopia, with very low myopia. So in them, I usually stress a lot for outdoor activities and reduction of near activities, and observe them closely.
Right. I think Dr. Nilutparna already told us that
Yes.
you have a lower threshold of because your progression is higher when you see it in
Yeah.
in your population, in the ethnicity there. But what is the I'm just discussing this because this is probably the more clinical portion of what we need to do. So what is the counseling that you do for the parents, Dr. Nilutparna, when you are planning to start something like this?
Yes, we definitely do a treatment counseling for all the parents. I usually have a counseling session every 3 months for those children who are diagnosed with myopia, and then at the 3 months when they come for follow-up at the first 3 months, at that time I make them sit down. I show them all the documents, like especially the biometry, the axial length, and the cycloplegic refraction, and whatever is documented. I usually sit with them. I discuss things with them. Usually in the first sitting, we see what Dr. Rebecca and Dr. Shalja has already pointed out, that in the first sitting, I don't go ahead with all this treatment. So I just give them the glasses, whatever they are wearing, and this document if there is any progression with their previous glasses. And then we call them on the 3 months, and then we sit with them. We talk to them about if both of them are myopes, or if only one parent is myope, what could be the successive thing for the child. And then we talk about what are the recent trends that are going on with the treatment of myopia, and what should be the lifestyle modifications of the children. So those are simple tips that we give. And we also take the consent of these parents, whether they really want to go ahead with this pharmacological therapy. Because you see, I would definitely want to know from other panelists also at this point that there is at the end of a year, sometimes we do not see a decrease or slowing down of the progression in these children. So what happens is that the parents do ask us, you have started with these drops, now what do you do? Sometimes if they don't come after a year or something like that, they just stop it. Like I tend to slow down give it on alternate nights, and then slowly decrease it, like for a washout, because at the end of 1 year there's a cumulative effect already happening in the child, like the deposition of the atropine itself. So at this point, at the end of 1 year, it is little difficult definitely to counsel these parents. But what can I say? I also have one question for Dr. Shalja also. During this COVID pandemic, I have come up with some children who were -3 and now has shot up to -6 even with atropine. I don't know what I'm supposed to tell them now, because I cannot blame everything on their near work or their screen time or the COVID pandemic itself. But I have really seen there is a 2 times 3-fold shot of myopia increase. So yes, definitely counseling is very important.
Yeah, but as shown in the paper, and I think everybody's experience, it is not like a blanket thing for everybody.
Yeah.
I've also have children whose parents complain they are totally hooked to the mobile or there, and still they don't progress. And the parents actually come with an expectation that they would have developed the progression, and I'm saying no, they are fine.
No, yeah,
then they expect me to counsel them to again refrain from mobile. And some smart kids, you say, but my glasses power has not changed.
Yeah,
so
exactly.
I mean, and frankly speaking, there is no evidence that mobile increases myopia. There is evidence that lack of outdoor activities increase. So it's like the child who doesn't play outdoor resorts to mobiles and resorts to more near reading or this, and that is why it is probably the culprit. So it is an indirect thing. So if children can balance both, probably that would be the best way to, yeah. Of course, now the problem here is the parents say that we can't refrain mobile because schools are online. Some of them don't have computers. Some of them don't have even a smart TV to project. So in that case, counseling becomes very challenging, very difficult, as you have said. You can't even say that stop them altogether. Some of the parents, in fact, I have some parents who would say that they have stopped school for a year because of this mobile exposure.
Yeah.
And
That's true.
again, I don't know how to counsel them.
No, I think that we must tell the parents that there's no proof saying that this is going to happen because of mobile. So please don't deny the child education. That I've had with a couple of parents, and I think we've emphatically to kind of put emphasis that that is not how it works.
Yes, I did the same. So
I think so. We just have a quick minute left, before our time gets over. So I want to come now to Vaishali to see how has your experience been in reading this paper? What I mean, has this helped you look at the research papers differently? A quick word from you. You've done all the effort, and then we'll conclude after that.
Definitely, sir. Right from preparing the PPT, right, like starting to read the paper to how to analyze it properly and putting it out to the audience, I've learned a lot. And this was a very enriching experience for me, sir.
And how much did you trouble Dr. Rebecca? Did you keep running to her?
A lot, sir.
Not at all. Not at
a lot,
all.
sir.
It's the best we have, sir, right now. So I was pretty, relaxed that everything is going to be fine. And she has actually herself written a review on myopia. So I was very confident that she's going to handle it well. So, yeah, thank you so much, Vaishali. Yeah.
Thank you, ma'am.
Chalo. And I think Dr. Sen Gupta, Dr. Kaushik, last words from you. Anything that you want to add to the discussion?
No, sir. That discussion was actually very nice.
Well, I think it's important to tell parents that this is the best we have, right? So you take it or leave it. If it doesn't work, we are working on other things, like DIMS and other concentrations, but this is the best we have today. So we do a lot of counseling and retina practice. So I think we are slightly better off, because when patient gets injection and doesn't improve, it's a lot worse than putting drops and not still worsening. So this is the best we have, and that's I think one thing. Other thing, quickly I wanted to also point out that a population which has a larger delta effect, or populations who are known to progress more, say 1 to 1.5 diopters a year, are probably better populations to study these effects of these these modifying agents, compared to a population which doesn't have that rapid progression. So there's a bit of a ceiling effect to how much we can sort of uncover in our populations. So these are probably better studies to hang on and sort of derive. And it's all, of course, good to say that there are ethnic differences, but still these studies are probably also very helpful. So we should probably take a look at them more closely.
Yeah, thank you. I think that makes great sense. So, at the conclusion, I think we don't have any specific audience questions, but you can always write into us. And if there's any doubts or questions, all of the expert panel, and we'll all be happy to answer. And I want to thank Dr. Vaishali for taking out time and preparing this paper for all of us to discuss this paper. Dr. Rebecca for mentoring her and for giving her inputs. Dr. Sen Gupta, Dr. Kaushik, Dr. Shelja, Dr. Bhavna, I think will join us in today, as well as Dr. Nirud Parna. So thank you all of you for the time, and thanks to all our audience, for all of you who've joined in and who are watching. Stay tuned for the next edition, and please apply for the YOSI Journal Club if you want to present something. As you heard from Dr. Vaishali, when you're reading a paper from a point of presenting in a journal club, there's a lot more you learn than just reading a paper on its own. And from our side, good night to all of you, and thank you. And special thanks to Dr. Devakant, the Secretary of YOSI, who's been handling the technical aspect of it for us today, and he's been patiently sitting with all of us in this session. So thank you there, and good night and bye-bye, everyone.
Good night. Bye-bye. Thank you so much.